One of the Healthy People 2020 goals is related to cardiovascular health. Hypertension is one of the main preventable risk factors for cardiovascular disease. The goal is to improve cardiovascular health and quality of life through prevention, detection, and treatment of risk factors for an MI. Currently, more than 1 in 3 adults live with some type of cardiovascular disease, and it is one of the leading causes of death. It can also result in serious illness, disability, and decreased quality of life, and hundreds of billions of dollars in economic loss each year. Here are your student learning outcomes. This is related to perfusion. Obviously, we're talking all about hypertension. And most of you, if not all, should have given many of these drugs, and you should know these drugs and how to give them, what to look for, etc. So we're going to get started here. This table is taken directly from Hoffman, your text, on page 598. It's table 31.3. And these numbers have changed in the last few years, and you will continue to hear hypertension is, greater 140 or greater systolic and greater than 90 diastolic, and you will continue to hear that. Many physicians continue that practice in those numbers, so don't expect to be getting orders for a blood pressure of like 140 over 89. Even the American Heart Journal Hypertension published an article May 6, 2020, so that's pretty recent. It cites a systolic blood pressure greater than 140 and diastolic greater than 90 as to be considered hypertensive. So just FYI. But we will go by these. So here are some of the stages: normal hypertension, pre-hypertension, stage 1, stage 2, and then we get into, and I did put here, hypertension crisis is not in Hoffman, but you need to look at that. And what you look at there is for an urgent is the diastolic greater than 120 and no obvious target organ damage. So that is your eyes, kidneys, etc. And an emergency is greater than 120 with evidence of target organ damage. So those are damage to the heart, the eyes, kidneys caused by that hypertension. So you don't want to decrease that blood pressure, though, very quickly, because organs are used to having that high pressure, unless it's an emergent or an kind of an urgent situation to where that blood pressure spikes really quickly. So you want to decrease the MAP, and that's your mean arterial pressure, by 10 to 20% in that first hour, and then further decrease it 5 to 15% over the next 23 hours. That's for those of you who are working in the ICU, the ER, etc., EMS. But be careful dropping that pressure too fast, too quickly. It's related to the ischemic damage in vascular beds that are habituated to that high blood pressure. And sudden drops in that pressure causes ischemia. So it's just an FYI. That will not be on your exam about decreasing the MAP, how quick, how fast. But it is something that you need to know about and to remember when you start working as an RN. So technically, when patients are seated, this is how to properly measure a blood pressure. And it should be charted if the patient was sitting, standing, lying, which arm, right or left, which cuff size is used. So the patient should not be talking. The feet should be flat on the floor. No smoking, caffeine, or exercise in the last 30 minutes. And I'll just tell you, every smoker that walks into the emergency room smokes before they come inside. You're supposed to, this says you're supposed to do 3 measurements and average the last 2. I have never ever seen this done on anybody, and I myself do not practice this. This image, though, is from the American Heart Association journal, Hypertension. So maybe we should be practicing this advice here. So cardiac output, guys, is the result of stroke volume, which is a quantity, times the heart rate. So you can see how the heart rate can increase or decrease the cardiac output, as can the stroke volume. And what is cardiac output? It's the amount of blood that the heart pumps through the circulatory system in a minute. So normal is 4 to 8 liters a minute. So that is about, 4 liters is 4.7 liters actually, is 5 quarts of blood. So that's how much your heart pumps every single minute. So in stroke volume is the amount of blood ejected from the left ventricle with each beat, and that's around 70 mLs. So what if that left ventricle is ejecting a decreased quantity of blood? In the case where left ventricular function is affected, like with an MI, so that's just something to think about. That is going to lower that cardiac output. Tachycardia, when your heart rate is up, guys, it increases cardiac oxygen demand, it increases workload, and decreases the stroke volume because of the decreased filling time. So those ventricles don't have time to fill because the heart rate is so high. So tachycardia increases cardiac oxygen demand, increases the workload of the heart, and it decreases the stroke volume because there's not enough filling time. You got to understand this concept that the amount of cardiac output is directly affected by heart rate and stroke volume. And the goal of meds is to decrease that cardiac workload by changing the stroke volume, the heart rate, the preload, afterload, and contractility and conduction through the system. So that's how most antihypertensives work. Factors that affect arterial circulation are blood flow, SVR, which is systemic vascular resistance, and blood pressure. So blood pressure, what is it? It's the force exerted against the walls of the arteries as blood is pumped through the circulatory system. I know that's basic, but the systolic pressure is the pressure in the arteries produced when the heart contracts. The diastolic pressure is the pressure in the arteries during relaxation of the heart between beats. So that's the amount of pressure that's always, the minimum amount, always on those vessels. Cardiac output, remember, is stroke volume, the volume of blood pumped per beat, and of course the blood flow through the circulatory system requires sufficient volume to fill blood vessels. So cardiac output equals stroke volume times heart rate, which we've already talked about. You got to remember that, got to know that. Systemic vascular resistance, that is the amount of squeeze or resistance that must be overcome to push blood through the circulatory system. So systemic vascular resistance is what the heart really must overcome to get blood out through the circulatory system. And of course, blood flow through the circulatory system requires sufficient pressure differences within the system to allow blood to move forward. So blood pressure is the amount of volume, the output, which is a quantity, times the resistance of that systemic vascular resistance. So physiology of blood pressure, we got a lot of factors that play in here. And your sympathetic and parasympathetic nervous systems are primary mechanisms that control your blood pressure. Stimulation of the systemic nervous system, or sympathetic rather, it affects peripheral resistance by causing vasoconstriction of arterioles, and that will increase your blood pressure. So you've got receptors too. You've got the parasympathetic system stimulation causes vasodilation of arterioles to decrease blood pressure. Baroreceptors located primarily in the aortic arch and the carotid bodies, they are sensitive to pressure and chemical changes. Kidneys, they also help maintain blood pressure by the excretion or conservation of sodium and water. Temperature can affect peripheral resistance by vasoconstriction or vasodilatation. So cold vasoconstricts, we all know this. Warm vasodilates. Diet too is a huge factor in hypertension. So high sodium, etc., preservatives, prepared foods. Race, gender, age, weight, and time. Race, African Americans are at the highest risk, also have more difficulty controlling hypertension. Our blood pressure increases as we age, so that is a factor there too. And is probably related to decreased arterial compliance or hardening of the arteries. So they're more stiff. Weight, the more weight, the higher the blood pressure, and time of day too. The lowest time that your blood pressure, or the time of day that your blood pressure is the lowest is in the morning. So hypertension is a silent killer. There are no pain, no symptoms, and it targets specific organs, and they're listed here. Typically, chronic hypertension doesn't produce any symptoms, and most people, unless they have their blood pressure checked or go to the doctor, they have no symptoms until it's too late, and they're not even aware that they have hypertension. No symptoms, though, that is, until those target organs start showing damage. Chronic hypertension affects the smallest vessels first, and those smallest vessels are in the brain, the heart, the kidneys, and the retina. And what happens though, so you've got small tiny vessels in those organs. And just like a hose left out in the sun, the biggest hose isn't going to have the most damage to it. It's going to be that small one because of those higher pressures on that tiny little vessel. The smallest vessels are found, like I said, in the brain, the heart, the kidneys, the retina, and in that all-important male part, the penis. The penis can also be negatively affected by chronic hypertension, causing erectile difficulty. Hypertension keeps the arteries that carry blood into the penis from dilating the way they're supposed to, and also makes the smooth muscle in the penis lose its ability to relax, and as a result, there's not enough blood flow to make the penis erect. Perhaps if enough men were educated on this, they would be more motivated to keep their hypertension under control. And chronic hypertension over time, it affects the vascular system. Damage to blood vessels that supply, of course, blood and oxygen to the brain can result in CVAs or TIAs, and it can affect the kidney vascular, the renal vascular, leading to progressive loss of renal function. And it also affects tiny vessels in the retina, leading to retinal bleeds, retinal detachments, and possible blindness even. These are classifications of hypertension. Essential, also known as primary hypertension. It's the most common. There's no specific cause. It leads to irreversible damage, And major complications, like we just talked about, cardiovascular, such as an MI, CVAs, peripheral vascular disease, renal failure, and retinopathies. Secondary hypertension is from an identifiable cause. So you know what it's caused from. For instance, it could be caused by medications or a kidney disease, and one of the most common is related to renal disease affecting filtration and also renal artery stenosis, so there's not enough blood flow. You can have those stents placed to open up those arteries and decrease the pressure in the case of renal artery stenosis, so that can be repaired. Excessive alcohol and oral contraceptives is also a common cause of secondary hypertension, as is chronic NSAID use, corticosteroids, think about your COPDers there, cocaine use, big time problem there, and licorice. Licorice also, believe it or not, will raise your blood pressure. Some endocrine issues that you can have, like the adrenal gland disorders, as in Cushing's syndrome, that can cause hypertension. Tumors in the adrenal medulla, that can also cause your blood pressure to elevate. And those meds there, like we talked about, the oral contraceptives, corticosteroids, antidepressants, particularly your tricyclics and your SSRIs can do it. Decongestants, of course, we all know that. Amphetamines, and don't forget pregnancy, because that increased volume in the pregnant female, and then of course other tumors too can cause hypertension. So you got to know your differences in your primary or essential and secondary. So there's two classifications here. Malignant hypertension, also known as hypertensive emergency or hypertensive crisis, is a medical emergency. It usually comes on very rapidly and progresses quickly, and you need to treat it rapidly. It's defined basically by diastolic blood pressure greater than 120 millimeters of mercury with evidence of target organ damage. And it is associated with acute target organ damage. So what you're going to see there is changes in lab work, basically, and I'll go over that in just a minute. But the treatment for this is fast to prevent a CVA and hypertensive encephalopathy, altered LOC, retinal damage, an acute MI, and renal or kidney failure. There's the cerebral artery in the brain actually spasms to protect the brain from excessive pressures, but cerebral edema can develop. So it's a really cool protective mechanism there, that cerebral artery actually spasms to protect that all-important brain. So typical treatment is nipride. It's a powerful vasodilator, onset within 1 minute, short half-life of 10 minutes. It vasodilates arteries and veins, and you never infuse this at maximum dose greater than 10 minutes. This is the reason why is because of cyanide poisoning, because in the metabolism of it, cyanide is a byproduct of nipride metabolism. So you never want to infuse this at a max dose for longer than 10 minutes. It's 10 mics per kilogram per minute. And I'm telling, this is, yes, a critical care drug, but I'm telling you this because you might have to start this drug on the floor, and you will need to probably have some help monitoring this, but it is a pretty powerful drug. Nitroglycerin too is included here. You might be starting nitro. It's a venodilator rather than arterial. It's a little slower onset, 2 to 5 minutes. Yes, you do get a headache still. related to that, vasodilatation. Also, maybe some labetalol will be used, or hydralazine will be used. So one of the things that target organ damage to look at, there's a chart on page 598 in Hoffman, as table 31.4. And it really it shows like renal damage. You're going to have proteinuria, elevated BUN and creatinine. If there's some endocrine organ damage, you're going to look at an elevated sodium, potassium, TSH, and it also talks about fasting glucose greater than 100 with some metabolic issues, some elevated LDL, triglycerides, and a low HDL. Also talks about a left ventricular hypertrophy, and the reason why that occurs is because if that left ventricle, that it pumps out to the brain and to the rest of the body, oxygenated blood, of course. And if the vascular resistance, systemic vascular resistance, is high, that ventricle must pump harder. And it's a muscle, so the more you use it, the bigger it gets. So you would see this with long-term high SVR. And also your book, guys, it says a lowered hematocrit. I believe your book is wrong. You would see an elevated hematocrit. And if someone can come up with something and show me why the lowered is correct, I would love to see it. So anyway, because when you have your hematocrit, of course, it's a determinant of blood viscosity, because it measures kind of the thickness of the blood. That's viscosity. And it measures, it's proportional of the RBCs in the blood. And most hypertensive patients have an elevated hematocrit, almost always. So anyway, but this is why what you would see, always look for an elevated, and if anybody can find a lower hematocrit reason why, I'd love to see it. Forward me that article in an email, please. Love to see it. All right, let's move on here. Genetics, of course, plays a role. Family history puts you at greater risk. Age and sex. Also on page 596, it states that men have a higher risk until 45 years old, and then women from 45 to 54 have a slightly higher risk than women greater than 65 have a much higher risk. Pediatrics, we are seeing a big increase in hypertension in the pediatric population today. And probably, more than likely, that is related to decreased activity, screen time, diet, obesity, and particularly with the COVID restrictions, people staying home, etc. So that's my 2 cents anyway, or for that. Insulin resistance, it can increase blood pressure via increased renal sodium reabsorption, activation of that sympathetic nervous system, and alteration of transmembrane ion transport, and hypertrophy of resistance vessels. And conversely too, hypertension can cause insulin resistance by altering the delivery of insulin and glucose to skeletal muscles, resulting in impaired glucose uptake. So you've got it's both ways there. But that is just something that's one of the risk factors for hypertension, of course, is insulin resistance. Obesity, correlation is well documented, but exact cause is unknown. Some cause can be attributed to the neuroendocrine mechanism, because obesity affects hormones and the renin, angiotensin, aldosterone system, and adipose tissue, which all affects, the adipose tissue certainly affects kidney functioning. Tobacco use, tobacco is a vasoconstrictor, and that obviously causes hypertension. And physical inactivity, sitting around doing nothing. So there's an image here environmental factors, genes, of course, genetics, there's a problem there. Race and gender, too, is an issue. African Americans are at a greater risk. Signs and symptoms of hypertension, they may be asymptomatic. They may not feel a thing. So some of the symptoms, though, that they will see, signs and symptoms: headaches, facial flushing, dizziness, fatigue, shortness of breath, fainting, nosebleeds, vision changes. Other signs might be from organ damage. So when you say the blood pressure is high, when taking a blood pressure, remember always, guys, we've talked about this, use an accurate sized cuff, not while the patient is talking, not after they've rushed into the emergency room or they've just smoked. Let them relax a minute, get their arm resting at heart level. Take it in both arms if you need to, and do a manual. Guys, if you take it again and it's still high, they've calmed down and it's still high, do a manual, verify it, make sure it's good. Make sure that you're doing it on a bare arm. I have done it not on a bare arm, but if it's off, if your readings are off, high or low, always, always, always take all the ways you're supposed to do it and do it properly. And what about those obese patients whose upper arms are so large that the cuff just kind of rolls over on itself when you're using the machine? You can take a forearm pressure. Just always remember to document it that way, that it was taken in the right or left forearm. And if it's really high, like I say, remember, take a manual blood pressure and always, always, always recheck it manually to verify, and know what the mean arterial pressure is, the MAP. So you need a minimum of 65 millimeters of mercury for organ perfusion. So that's 2 diastolics plus a systolic divided by 3. That's how you get that. Most of your machines, though, will calculate that for you and give it to you. So don't call your doctor and say, oh, his blood pressure is really low. It's, I don't know, 90 over 64 or whatever it is. Always call them and tell them the pressure is low, it's this, and this is the MAP. They will really, really appreciate that. That tells them that the mean arterial pressure in those organs are being perfused. Some of the things also that you might see here is adult coarctation of the aorta. It's evidenced by elevated blood pressure in arms. They're higher and it's lower in the extremities. So the femoral pulses are delayed or absent, and the blood pressure in the lower extremities is much, much lower. And what is coarctation? It's a narrowing of the aorta. So that's how you're going to see that. And that makes perfect sense because that left ventricle pumps out the aorta down to the rest of the body. So if there's narrowing of that aorta, pressures are going to be pretty good upper and then not so good lower. So these are some of the things you're going to see with hypertension, and of course your measurement, your blood pressure measurement. So some diagnostics. What we're going to do is we're going to get a 12-lead cardiac tracing looking for left ventricular hypertrophy. You're going to look at that R wave and the amplitude of it. And for those of you working in the ER or critical care, you're going to see that R wave in AVL greater than 12 millimeters up. Or you're going to see the S wave in V1 plus the R wave in V5, and if that sum is greater than 35 millimeters, that means you've got some left ventricular hypertrophy. That is not something you guys need to know. So I'm just telling you that for those of you who work the ER or will be critical care, EMS. So they're going to look, and that's how you can find left ventricular hypertrophy on a 12-lead. So you're going to look at that 12-lead, and that's what they're looking for. Look at that UA. Is there protein or RBCs in the urine? going to get a metabolic panel, look at that sodium, potassium, BUN, and creatinine, looking at that kidney functioning. The CBC, that hematocrit, where is it? Up, down, indifferent? A chest x-ray. What in the heck? Why a chest x-ray? So what they're looking for is cardiomegaly, which is an enlarged heart, and to see if there's any rib notching. And what that is, and I put a photograph here, an image rather, I should say, of a chest x-ray, and you can see some notching on those posterior ribs, usually third and fourth. It's caused by high pressures with coarctation or narrowing, and the pressure is so high in the posterior intercostal arteries, they dilate and pulsate, rubbing off the actual ribs, the bones. So the image shows that rib notching, which is, see the little kind of grooves in there, and that's what rib notching is, which is absolutely insane, that high blood pressure could actually rub off bone. Let's see what else here. Creatinine clearance, we're going to check that GFR. Decreased levels equals, you're going to look at that kidney function there, and that means a decreased kidney filtration. Lipid panels, you're going to see a low HDL and a high LDL, which is just the opposite of what you want. Triglycerides will also be elevated. So this testing is usually performed to evaluate the causes, the risk factors, and then the presence or absence of target organ damage. So that's what you're gonna look for. These are the diagnostics that you're gonna see, your docs are gonna order. Lifestyle modification, our diets pretty much are killing us. High sodium intake, we're going to probably put them on a DASH diet, which is high in fruits, vegetables, and low-fat dairy. Too much screen time, we don't have enough physical activity. And stress reduction, some yoga, Tai Chi, exercise, get outdoors, and religious and spiritual beliefs, which we just kind of talked about. Lots of changes. So, decrease that alcohol intake, stop tobacco. So that is a lot of lifestyle modification. And, what if you were told, change your diet, you got to exercise more, you're going to reduce your stress, you're going to stop drinking, you're going to stop smoking. That is a lot of change all at once. So patients usually, they feel a loss of control with all this, start that, stop this. So give them some options, something that they can have control over and do just one thing at a time. We're just going to change one thing at a time and give them some control and choice in the matter, obviously. So here's the DASH diet, which is dietary approaches to stop hypertension. And the weight loss is recommended for obese patients, of course. And the DASH diet is proven to be beneficial, and it's used to manage hypertension. And it's managed by reducing sodium intake, maintaining adequate potassium and calcium, and reducing total and saturated fat intake. A mild to moderate sodium restriction, so that just really means no added salt. And so sodium restriction actually lowers blood pressure and potentiates the effect of antihypertensive drugs for most people. This diet is, of course, rich in, as you can see here, veggies, fruits, low in dietary, not dietary, but dairy, and low in cholesterol, total unsaturated fats, high in fiber, potassium, calcium, magnesium, moderately high in the protein area. So that's some of the things that you can do, and this is really in the DASH diet, because you'll see that people put on this a lot. So hypertension pharmacologic therapies. Lots and lots of different classifications to choose from. lots of meds to decrease that blood pressure. What happens physiologically if that blood pressure is too low? So what changes would we expect to see if we get it too low? We're going to have some weak pulses, cool peripheral extremities, dizziness, diaphoresis, pale, slow cap refill, right? And of course check for orthostatic hypotension. So with all these therapies, a lot of them will cause that the blood pressure might get too low. So what does the body do to compensate? It increases the heart rate. That's a compensatory tachycardia. That's what that's called. It's the body's attempt to raise that blood pressure and get it up if it's too low. Elderly people, guys, watch for hypotension, particularly they are affected, elders are affected by that first dose effect. So really, really watch them. And this is just kind of an overview for all of the hypertension pharmacologic therapies. And there are, you can see here, many, many different classifications for them. So, antihypertensive, guys, we have got many, many, many classes here, but these in particular, the calcium channel blockers, you do not stop them, or the beta adrenergic blockers without seeing a doctor first. These things, you can have a horrible, horrible rebound. So these, you do not stop them without consulting your physician, and they must be weaned off. Diuretics, they decrease intravascular volume, thereby reducing blood pressure. So we have some different classes here of diuretics: thiazide, loop diuretics, and potassium-sparing diuretics. A lot of times it's the first line of treatment. They're relatively safe, usually pretty well tolerated, and sometimes carefully used in combination with other antihypertensives. It may, usually is the first line of treatment, like I just said. African Americans typically will need to have a diuretic added to their regimen therapy for their hypertension. Thiazides. You have your hydrochlorothiazide, your microzide, urozide. They prevent water and sodium reabsorption in distal tubules of the nephrons. So you can see here, it's kind of a cartoony thing, but it is of a nephron, and it shows the loop of Henle down there. That's your loop diuretic, such as furosemide or Lasix. And it also shows where the you lose sodium and sodium chloride, and you have potassium. So watch for that low blood pressure, your low sodium, your low chloride, potassium, and dehydration is a big deal too. So you're going to lose some weight because you're going to lose some water. Make sure you do an INO on these people that are on these diuretics. So loop diuretics like Lasix or furosemide, you have bumetidine, which is Bumex, and it is typically used for congestive heart failure, but it can be used just for hypertension and in those allergic to Lasix. It also prevents water sodium reabsorption, but it is in the loop of Henle. So that's where it works, the mechanism. What to watch for, like I talked about: low potassium, sodium, magnesium, hypovolemia, and dehydration. Hyperglycemia, high blood sugar. That mechanism is not completely understood, but it's associated with insulin resistance. Hypokalemia is the most common side effect, though, with diuretics, especially the loops. So be careful with that, and that's a big deal. So aldactone or spironolactone is a diuretic, and it acts on the distal tubules in the nephrons in the kidneys. It inhibits reabsorption of sodium in exchange for potassium. So it holds on to potassium, and it gets rid of water, and it blocks the aldosterone in the kidneys. So you're going to have to watch very much so for hyperkalemia. You need to teach the patient to decrease foods that are high in potassium, report weaknesses or irregular pulses, which are indications of high potassium or hyperkalemia. They're going to limit bananas, oranges, cantaloupe, honeydew melons, apricots, grapefruit. Some dried fruits such as prunes, raisins, and dates are also high in potassium. Cooked spinach, cooked broccoli, potatoes, sweet potatoes, mushrooms, peas, cucumbers, zucchini, pumpkins. Gosh, I couldn't live on this. Leafy green vegetables, lima beans, pinto beans, kidney beans, soybeans, lentils. So this medicine is really, you got a major issue with potassium here. It holds on to potassium, so we really need to monitor that. Watch for, like it says here, headache, diarrhea, electrolyte imbalance, of course, fatigue, and GI disturbances. Alpha adrenergic blockers, antagonists. So agonists produce an action, antagonists opposes an action. So alpha adrenergic blockers, they block the alpha receptors in vascular smooth muscle, and it decreases vasomotor tone and vasoconstriction. So doxazosin, which is a BPH drug, you should remember that, has a high affinities, like we said, to the receptors in the prostate, which is smooth muscle. Vasodilatation may cause orthostatic hypotension and reflex stimulation of the heart, resulting in tachycardia and palpitations. Beta blockers may be ordered, though, to minimize those effects, so because it would keep that heart rate from going up. This is not for use in pregnancy because it's a smooth muscle relaxer. The uterus is a smooth muscle, and we don't want that all relaxed out. So it decreases vasoconstriction and decreases peripheral vascular resistance by dilation of arteries and venous vessels. Sometimes used in combination with other meds, but not for use in pregnancy. Centrally acting alpha agonists, such as clonidine, methyl-dopa. These medications are centrally acting alpha agonists. They reduce sympathetic outflow to the heart, stimulates receptors, and decreases blood pressure. So it decreases heart rate and contractility, that's the squeeze of the heart, therefore decreasing that cardiac output and therefore the blood pressure, so it's lowered. These are not usual first-line drugs, and you do not stop these suddenly. There are many side effects here with these. Dry mouth, sedation is very common with these, headaches, peripheral edema, orthostatic blood pressure, or hypotension, severe reflexive hypertension if discontinued abruptly. So that's why we do not stop these suddenly. Use as an adjunct with diuretics or when others have failed, or in the case of Aldomet or methyl-dopa for pregnant women. So methyl-dopa is a prodrug, and it must be metabolized into an active form of medication, usually by the liver. So Aldomet is metabolized in the central nervous system to produce the active form of this medication. Okay, it's not in the liver though, but it's used. This one is metabolized in the central nervous system. Okay, so a prodrug, like I said, it needs to be metabolized into an active form of the medicine. So it's got to be metabolized first before it works. Alpha blockers, like most antihypertensive, can cause vertigo, palpitations, and can also cause sexual dysfunction. A lot of people don't want to talk about that part of it, but that is a major issue. Many men will stop taking their antihypertensives because of erectile problems, and they don't want to tell their doctor about it, so they just stop taking it. Little do they know the effects that it's really having that we talked about previously here. Beta receptor blockers. Beta blockers occupy the beta receptors with various effects. So we're going to talk about beta 1 and beta 2 blockers. Guys, there's even beta 3, but we're not going to talk about those. So beta 1, beta blocker 1s are also called cardioselective drugs because the beta 1 receptors are primarily on the heart. And you can remember this, by beta 1 you have one heart. So I put a picture of the heart over there for you. Beta 2 receptors are located on the smooth muscle of the bronchioles in the lungs and blood vessels as well. So remember, the non-selective beta blockers such as Coreg or carvedilol and labetalol, propranolol, and sotalol, we would be awful cautious with these. So these are some of the drugs over there that you need to be really careful. These are beta 1 and beta 2 blockers, and maybe some other ones as well. And these have 2 lungs, so these are beta 1 and 2. So 1 heart, it's beta 1, beta 2, 2 lungs. So when beta 2 is blocked on the bronchioles, it increases that bronchial smooth muscle contraction, producing a narrowed airway. So we have to be really, really careful with these non-selective beta blockers in giving them to patients with, particularly with what disease process? Who would we be really careful about giving these to? COPDers, of course, because we don't want to narrow those airways any more than they already are, right? So we talked about these and beta blockers. They're your LOLs, but we do have 2 types that we're gonna be responsible for, the beta 1s, and they decrease that heart rate by slowing conduction down from that SA node to the AV node. Remember, in the heart, that conduction system, and decreases myocardial contractility. So if it decreases that squeeze, it's going to decrease that cardiac output, and it also decreases myocardial oxygen demand. It's not beating as fast, it's not needing as much oxygen. That squeeze is softer, it's not as much output, so that heart, that muscle, doesn't need as much oxygen. So just kind of keep that in mind, and you need to understand this, guys. We're stepping up to the plate here, going deeper. So how do these, like I talked about, how these worked? Like, I'm going to repeat this again. The beta blockers block the beta 1 blockers do on the heart, reducing myocardial stimulation. This reduces heart rate, slows conduction, SA node down to that AV node, and decreases contractility, thereby reducing myocardial muscle oxygen demand and blood pressure. So that's your metoprolol and like your atenolol. And it also blocks sympathetic fight or flight response. So your non-selectives, those beta 1 and 2, they also block the beta 2 receptors on smooth muscle of the bronchioles and the blood vessels. So when that beta 2 is blocked, that bronchial smooth muscle contracts, narrowing the airway. So be careful with carvedilol, propranolol, and labetalol because they affect the beta 2 also. There's a chart in Lilly. It's on page 315. Probably should look at that. Beta blockers, though, are considered a first-line treatment for hypertension. And they have several uses, though, too. It's not just for hypertension. So because they affect that cardiac workload. They decrease that oxygen demand. They can decrease the symptoms of angina. It also, like I talked about, slows conduction. So they're helpful also in certain types of dysrhythmias, like SVT, AFib, VTach, and some dysrhythmias during pregnancy. And beta blockers generally lower that blood pressure. Here we are again, decrease that cardiac output by lowering the heart rate and decreasing contractility. Can be used too for heart failure, MI, and migraines, and anxiety too. Many a student has gone on beta blockers to slow that heart rate down, calm them down before exams, for instance. So we start with a very low dose. There's very limited side effects with a low dose. It can cause, like we talked about, that bronchoconstriction at higher doses, especially with the non-selective beta blockers. Remember? So that's beta 2. Be very careful with asthmatics or COPDers, and it can decrease libido and cause erectile dysfunction. And caution too with the diabetics, because they may not have the usual signs and symptoms of hypoglycemia because the CNS is blocked. Okay, so that is, they're not going to break out in that sweat, and so they may not feel that. Abrupt cessation may result in rebound hypertension, angina, and an MI. You got to taper these off over a couple weeks. So this image is for beta 1 blockers of the metoprolol, atenolol, and propranolol. Sorry. Side effects, guys, of course, orthostatic hypotension. Safety is a big concern in all antihypertensives. So use with care, with ambulation, get them up slowly. So they can be with these particular drugs, the beta blocker, beta 1s, bradycardia, slows that heart rate down, lethargy, some GI disturbance, even some CHF, and some depression. So how it works, it lowers that heart rate, decreases force of contraction, that contractility, and slows the rate of conduction. And this is just an image of everything I've said 4 or 5 times now. So anyway, just be careful with these patients. We're going to monitor that blood pressure, the heart rate, liver LFTs, because these drugs are metabolized in the liver. Watch, though, too, for agranulocytosis, because these are one of the side effects, too, that you can see with some of the beta blockers, too. Vasodilators. These drugs are highly effective at lowering blood pressure, but they have lots of bad side effects. As that blood pressure drops because of vasodilatation, the heart will attempt to compensate by increasing the heart rate. This is a normal compensatory action in response to a lowered blood pressure. That heart is saying, oh my gosh, I got to speed up and get that blood pressure up. So if the heart does that, if that pressure drops a little bit too low, that the heart says is too low, patients with coronary artery disease could experience an acute angina attack related to the increased workload on the heart with that reflexive tachycardia. So you got to be careful with these drugs. Vasodilators, they relax smooth muscle. It's not always the best choice, especially for the elderly, because they are very sensitive to vasodilators. It can cause serious complications, like I just talked about, that reflexive tachycardia, angina, and coronary artery disease, sodium and water retention too. Side effects, headaches, oh yeah, big time, dizziness, tachycardia, hypotension, And the drugs listed here are those that are in this classification of a vasodilator. And we give these a lot. Sometimes, though, if the patients are on a vasodilator, they may add a beta-1 blocker. Why? Why would they add a beta-1 blocker if this patient is on a vasodilator, but they keep having a reflexive tachycardia? So they're going to add that beta-1 blocker so that heart rate cannot increase. So they wouldn't have a reflexive tachycardia. My question would be, well, why don't we just switch to a beta-1 blocker instead of a vasodilator? But docs know how much more about this than I do. So as the blood pressure drops too low, the blood flow to that kidney decreases. So that's why that you can have some issues there. So renin is released if that blood flow to the kidneys is too low. Kidneys will hang on to sodium and water in an attempt to increase blood pressure and renal perfusion. Therefore, with the retention of sodium and water, the blood pressure raises, canceling that antihypertensive action of the vasodilator. So those kidneys will kick in and be like, oh, hey, wait a minute, this is too low. So you can give a diuretic to prevent fluid retention, but be very, very cautious with that. Excessive diuresis and lower blood pressure can occur. Here we go. We're back on to ACE inhibitors now. I changed the slide too quickly. Sorry about that. Anyway, ACE inhibitors, angioconverting enzyme. So that's what ACE is. It's an inhibitor. These are the prils, and I kind of remember this for those card players. You get a thrill when you see it when you have a prill. So that's how I remember the ACE inhibitors. I know it's silly, but it works for me. So it's often used in treatment of hypertension, very often. It blocks the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 is a very potent vasoconstrictor. So vasoconstrictors, you would get your blood pressure up. So if that is blocked, that blood pressure is lowered, and it reduces the peripheral vascular resistance. So think about that, guys. If the vessels aren't squeezed tight, if they're relaxed, the vascular resistance is lowered. And it also is called afterload. And remember, afterload is the resistance against which that left ventricle must pump to overcome that. So, and ACE inhibitors blocks the conversion of angiotensin 1 to angiotensin 2. And blood pressure is lowered by reducing the peripheral vascular resistance, or afterload. Same kind of thing. And afterload is the resistance against which that left ventricle must pump to get blood out. So it decreases blood pressure two ways. By lowering the vascular resistance, and it decreases intravascular volume because it has a really mild diuretic effect. Okay? So it also prevents sodium and water reabsorption mildly. It's not a huge diuretic, but it does cause some mild diuresis. So it decreases intravascular volume and therefore decreases the blood pressure also in that second way. That's the second mechanism of action. So ACE inhibitors enhance the effects of thiazides, and they are often used together for that. So, like I said, they may be used in conjunction with other antihypertensives. Captopril and lisinopril are the only two that do not need the liver function to be effective. So these two are not prodrugs. Remember, prodrugs have to be metabolized first into an active form. So these are not. So captopril and lisinopril are good choices if a patient were to have liver dysfunction, right? ACE inhibitors interfere also with the breakdown of bradykinin. And bradykinin is a vasodilator that triggers blood vessels to widen, and it becomes more permeable and leaky, which leads to swelling, which leads to a rare but serious side effect called non-allergic angioedema, and it can be life-threatening. Usually there's swelling around the eyes, the lips, and the throat. They may lose their airway. It usually develops within hours or days after beginning an ACE inhibitor medication. And a big red flag you need to watch for is puffy face, eyes, or mouth. The typical treatment, though, for allergic angioedema, like antihistamines, steroids, epi, doesn't work with this. So it is ineffective. The drug that they named here is Ictabant. ICATIBANT is used to treat this kind of non-allergic angioedema. I have never seen that drug, never used it. So side effects of ACE inhibitors are, of course, postural hypotension. You got to watch safety in all these. Most common side effect, though, with these is persistent dry cough. It's that ACE cough. Probable cause is because of that prevention of that bradykinin breakdown, resulting in an accumulation of protussive, so not antitussives, which is stopping a cough, but protussive, which produces a cough in the respiratory tract, thus the cough. So if a patient has a cough, and they've just started an ACE inhibitor, are you just going to say, oh, it's just a side effect of the medicine? It's just the ACE inhibitor. You need to listen to their lungs. Get an O2 sat. Check that respiratory rate. Don't just say, oh, it's ACE inhibitor. Yeah, you got an ACE cough. That's not acceptable. It has interactions, though. Make sure you watch this, guys. NSAIDs and lithium. And potassium-sparing diuretics. So caution with these. You need to be careful. Lithium and especially the NSAIDs, because NSAIDs are over the counter and people take them a lot with this. So be careful. Be careful with this. So drug interactions with those, and be careful with that. And especially with the elderly, and with this and ACE inhibitor, watch for that first dose hypotension effect, especially the first dose. This drug really does, it can drop their pressure pretty fast. So be careful with that. We may see some hyperkalemia. They might have to limit their intake of foods high in potassium, and the excretion of potassium is inhibited. And a lot of times I'll use a thiazide with this to get rid of the potassium. ACE inhibitors, like I said, reduce blood pressure by decreasing systemic vascular resistance, by preventing, or peripheral vascular resistance, by preventing the formation of angiotensin II. So there's a decrease in the afterload, or the resistance against which the left ventricle must pump to eject its blood volume. So guys, you're going to hear these terms, preload and afterload, but it's that simple. Afterload is just, like I said, the resistance that left ventricle must overcome to circulate the blood. That's all afterload is. So if you decrease peripheral vascular resistance, you have decreased your afterload. It's that easy. It's that simple. Sodium and water resorption is also reduced, and this causes diuresis, which mild diuresis, remember, which decreases the intravascular volume and return to the heart. So if there's less return, it's it decreases the preload. So just think about that. If they're peeing out, if they're diuresing, that volume is lowered. And of course, this is a contiguous circuit, but it also decreases that preload. And that's just the volume entering the ventricles. It's that simple. You're going to hear those terms tossed, oh, the preload's up or the preload's down. And it's not, it's that simple. It's that easy. So ACE inhibitors can stop the progression of left ventricular hypertrophy seen after an MI. So this is known as ventricular remodeling, and we'll talk more about this in NUR 213. But one of the reasons that it does it is because it decreases that afterload. Okay, angiotensin II ARBs receptor blockers. So these are the ARBs, and I remember this, and I know this is kind of goofy, but so they're the sartans, so that sounds like a sultan to me, and sultans wear big head garbs, so garbs are ARBs, and they are the sartans, so that's how I remember it. I know it's goofy, but it helps me, because that sultan over there, that picture, he has a big old garb on his head, so that's how I remember it. So ACE inhibitors block angiotensin I from becoming angiotensin II, right? ARBs simply block the angiotensin II receptor sites. So they don't stop II from being formed, they just stop it at the receptor site. So they block the receptors. They can promote hyperkalemia though, so we got to be careful with those. With that, or watch for that. And NSAIDs, interaction with NSAIDs again here, same one, just like the ACEs. So NSAIDs are a problem, and lithium is a problem. So NSAIDs decrease the effect of ARBs and cause a potential renal failure. Here, lithium elimination is an issue when you're taking ARBs or ACE inhibitors. Therefore, you're going to have some lithium toxicity. So these two medications are really, honestly, just basically contraindicated together. Initial dose adjustment for older adults, or you'll need to do that, or those with renal impairment, is not required, which is a big positive. So renal function isn't an issue with ARBs. And it is not, this medication, ARBs, are not as effective in some patient populations, such as African Americans, unless it's taken with a diuretic or a beta blocker or a calcium channel blocker, which we'll cover in a minute. Side effects, of course, include headache, dizziness, orthostatic hypotension, just like all the other antihypertensives. And listed here are some of the medications that are in this classification of the ARBs. This is contraindicated in pregnancy and lactation, and it's also a good option for those who have who will get an ACE cough, because it doesn't inhibit that. So it lets it convert it all the way to angiotensin II, and it just blocks that. So a lot of them will be put on an ARB if they get that nasty old ACE cough. And it is, that ACE cough may not be a big deal to you, but it is to other people. And they can't, most of them just absolutely can't stand it. Calcium channel blockers. Some calcium channel blockers are selective for arterioles, while others work on calcium channels in arteries and cardiac muscle. And this drug was actually first introduced for angina treatment. And so it blocks extracellular calcium from entering the cardiac and smooth muscle. Therefore, it dilates coronary or systemic arteries and decreases blood pressure. It also decreases afterload, pressure against which that left ventricle must pump, and increases myocardial O2 supply. and it decreases myocardial contractility, which also means if it decreases that contractility, it decreases that cardiac workload. It slows AV conduction, slows that heart rate from the SA node down to the AV node. And the only thing is, it possibly can cause like an AV block, an atrioventricular block. It could be that slow. It could cause it to go that slow. This is used sometimes frequently in AFib because it decreases that heart rate and decreases that AV conduction. Grapefruit taken with calcium channel blockers can lead to renal failure, heart failure, GI bleed, and death. Grapefruit is absolutely contraindicated with calcium channel blockers. Like I said, it's typically not used for hypertension treatment, and I've got it listed here. And this little image here shows VND, very nice drugs, and that's verapamil, nifedipine, and diltiazem. So that's what those calcium channel blockers are, very nice drugs. And of course, some of the things, side effects you're going to see here, we've talked about, and that's pretty much, guys, for almost all of the antihypertensives. So, CAM therapy, we're going to see here yoga and Tai Chi combined with imagery, meditation, physical exercise have been shown to reduce sympathetic nervous system activity, lower blood pressure, heart rate, and respiratory rate. You know, we just read that huge retrospective study showing many health benefits of religious and spiritual beliefs. And that really is important. Acupuncture, biofeedback, garlic. Garlic's a huge deal. That there is evidence-based practice that garlic does actually reduce your blood pressure. CoQ10 may benefit some patients with cardiovascular disorders, and this is the NIH stating this. And stress relief therapies, always, you know the drill. Check with your physician first before starting any CAM therapy. Nursing diagnoses, one of the biggies is ineffective health maintenance. We need to educate them on lifestyle modification, diet, their meds, activity, things that affect high blood pressure, willingness to take responsibility for management of this disease. That's huge. They have got to take this on. They have got to own it. It is theirs. It's their body, and they need to be responsible. It's very important for the patient to understand the progressive nature of high blood pressure, of hypertension, and the long-term implications. So we've got to talk to them about their meds, the time, you know, lifestyle modification, non-compliance, what it does. Talk to them about the penis if they're a male, because that will get their attention. Retinopathy, they don't want to go blind. They don't want to be on dialysis for the rest of their life. They've got to monitor lab work, drug interactions, safety with that orthostatic hypotension. Educate, educate, educate. Nursing diagnosis, imbalanced nutrition. I love this picture. There's nothing wrong with a pizza and a beer, guys, but it's one of my favorite meals. But the problem is the frequency. There's, you know, well-documented relationship of obesity and hypertension and excessive alcohol intake, particularly associated with central obesity, which is a larger waist larger than hips, and weight loss takes commitment, and a big, huge commitment. They need to set realistic goals, get a nutritional or dietary consult, support groups. Exercise is a huge part of this. Sedentary lifestyle is a real problem, especially in today's world. And food is used, you know, as a reward and stress reliever. I do it too. Weight Watchers, etc. Many of those who lose weight can stop their antihypertensive meds because they're no longer hypertensive, and even their diabetic meds. And if they get enough weight off, they really are able to stop many of their pharmacology therapies. That's a big, big plus. Another nursing diagnosis, fluid volume excess. So it obviously contributes to hypertension. The more volume, intravascular, the higher the blood pressure. So we're going to monitor them for signs of excess fluid. So what would that look like? Excess fluid in a patient. So, peripheral edema, orbital edema, their weight is up, they're not diuresing like they should, daily weights. So they have to watch their daily weights. They got to. And you need to discuss with them importance of adhering to that treatment plan and watch. Basically, the biggest thing for them patients at home is a daily weight. So if they're up 2 pounds, 2.2 pounds, that's 1 liter of fluid that needs to come off. And if they gain 2.2 pounds or in a day or two, it's water. It's water. Another nursing diagnosis is, non-compliance. And guys, some people, they just don't care. It'll be all right. I'll be fine. So lifestyle changes are overwhelming. Find one change that client has control over that they can do, and then another one, and add another one. And many, they just don't seem to care, and it's stressful. They'd rather just be in denial about it. It's not going to happen to me. It might involve major, lifestyle changes that they have to get control over. So educate, educate, educate. Loss of renal function, blindness, CVAs, MIs, and of course impotent. And most men will pay attention when you talk about that. So, and another thing too is, the risk for a CVA. I think one of the worst things to happen to somebody is to have a CVA, and they're basically, they can't move, they're in a nursing home, but their mind is still there. That's got to be the worst prison I could ever think of. So, talk to them about that. Some of them just really they don't want anything to do with getting better because they don't feel it. It doesn't hurt. They're fine. They're fine. So putting all this together, guys, how does blood volume, SVR, heart rate, affect blood pressure? We can talk about this when we meet next week. But blood volume, decreased volume, SVR, they all decrease that blood pressure. So if you have a lowered blood volume, you got less volume, you're going to have a lower blood pressure. Less resistance in that vascular system, lower blood pressure. Heart rate lower, lower blood pressure. Kidneys. Elimination from the kidneys is an indirect indicator of cardiac output because blood flows from the heart through the aorta, through renal arteries, and urine is produced because of this perfusion. Kidneys help maintain blood pressure by excreting or conserving sodium and water, plain and simple. If blood pressure is too low, though, the kidneys release aldosterone, which increases sodium reabsorption and water retention, thereby increasing the volume in the intravascular space and increasing blood pressure. So, and if that pituitary gland releases ADH, which decreases diuresis, it promotes even more renal absorption of water. So that can have an effect too. So fluid and electrolytes, sodium, where sodium goes, so goes water. Therefore, if sodium is held on to, so is water. Potassium promotes vasodilatation. Low potassium, calcium, and mag intake contribute to hypertension by unknown mechanisms. So watch potassium levels with diuretics. It's a big deal. Nutrition, obesity is a major contributor to hypertension. Mag, calcium, and potassium intake are important because mag and potassium actually reduce the blood pressure. Educate about meds, weight management, lifestyle changes, and result of what will happen with non-compliance. I think a lot of people, if they know the why and they know the what's going to happen, they're more likely to listen and to want to make changes in their life. So here it is, guys.